much. And thank you again to the Seniors College for this uh, gracious invitation. And I hope, again, everyone can hear me okay. I know there was some mic challenges earlier in the day, but I also just wanted to start with a very personal thank you and acknowledgement to both Drs. McGeer and Brown for their incredible leadership. As Stanley had mentioned, for Dr. McGeer through 2 pandemics, but for both of them through this last 2 years, I know they have made many personal sacrifices, but have really saved numbers of lives and been really fortunate for the opportunity to work with the science table at times. And again, the general leadership that has been there from both of them. So really honored to be here today. Virtually, sadly, I am looking forward, hopefully, to meet everyone and appreciate all the time and energy and the pre-interview and pre-sessions to prepare for today. And really am hopeful that we can all be in person soon. I did title the talk about the pathologies of poverty, again, and following Drs. McGeer and Dr. Brown. Again, I think it's speaking to the importance around leadership and the aspects of death and the modeling. It's really important, I feel, that as we have any time to reflect, that we do look through some of the stories and data about who has borne the brunt of the pandemic. And it's incredibly clear as we look at the last 2 years where that has fallen in our society, and really as a matter of policy failure, not individual failures. And I will start with the first slide, really to look through again that this has been a ongoing tale. I mean, I think we've called some of us have called this the tale of 2 pandemics in terms of who has been most impacted by COVID and the realities and choices that have been here. And in many ways, the limitations of our healthcare system have played out. And, we can actually look back to the Lalonde report in 1974, with full disclosure is before my time, but as a student of health policy and a student of what we continue to look at in terms of what has laid the groundwork in this report for what we have called the social determinants of health, which is really about how these social forces have dictated, especially the pandemic, who has gotten sick and who has the privilege to either stay at home or have access to other supports. Much of this was laid out actually in the Lalonde report before the UK and US. And it was great to see Dr. Brown's examples of some of the areas where the US and UK have had a much longer history around the kind of dynamic or structure when it comes to science and science-informed policy. When it comes to the social determinants of health, it was actually the Lalonde report before the Black report in the UK of 1980, again in 1974, where there was a minister of health and welfare at the time, again, talking about just in being able to show the connection between different social determinants that impact health. And one of the things, again, about how humbling it is to go back, as we all, again, as an assistant professor of health policy, thinking about new ideas, much of this was laid out in terms of we would not get very far if we did not address issues around the environment, climate change, housing, poverty, and many of the other aspects that are driving health outcomes. This early, and again, it was in 1967 or so where we saw the passing of universal health care, but quite quickly it was made clear from Lalonde that we would not actually realize many of the virtues if we did not address the social policy challenges. And fast forward to, this is a paper that Dr. Lapakis and I had written in February of 2020 with no anticipation, have to disclose, of a pandemic to come less than a month later in March of 2020, but really tried to reflect on the learnings and the outline of what had happened with respect to the Lalonde report since over that 45-year period or so, and really making the argument that if we don't address the pathologies of poverty, if we don't actually ensure that people are getting access to the supports and healthcare they need, that we are allowing unnecessary deaths to take place. And it ended with what I believed at the time, and still do, was meant to be a rhetorical question about whether or not children born in low-income neighborhoods deserve the same likelihood of living to the same age or having the same access to quality healthcare in poor neighborhoods versus affluent neighborhoods, if we believe that as a society. And if we did, then we had to make very meaningful reforms and very meaningful changes to the way that healthcare is delivered and the way we actually think about health. Our notions of health had to be upended. And again, unfortunately, I walked through a little bit of the last 2 years of where we might be on this question and some of the actions that do need, I believe, to still take place. I also wanted to lay out some data around some of the aspects. Again, we talk about our notions of health being beyond just healthcare, of, again, the importance of hospital beds and surgeons and nurses and primary care, but again, of where we've seen some very strong literature over the last 40, 50 years that, the air people breathe, where they live, the jobs they have, the income, and the relationships and supports have a far larger impact on one's life expectancy and on many other measures of well-being. And so when we look at, this is a terrific paper by Dutton and PG Forrest from Calgary in Alberta, just published in 2018 in the Canadian Medical Association Journal and CMAJ. We've really seen that over the last 30 years, there was a focus on health spending, with some provinces spending more in terms of seeing of an increase, and not the same concomitant rise in education and social spending that has taken place. And really, I think that one of the arguments to be made, today is that we've actually set the groundwork for the inequities and the real challenges that were exacerbated throughout the pandemic in the way that we spent public dollars. And I would make the argument actually not enough generally. So some people look at this, graph on health spending and say, well, this is a case of where too many dollars have gone to the healthcare sector, not enough to social spending. But if we actually look at some other evaluations from the OECD and elsewhere, as a percent on public spending, we actually spend far less on both measures compared to our peer nations for both social spending and health spending. So really on both, we continue to spend far less than the peers that we were measuring our COVID response to, such as UK, Japan, Germany, and other jurisdictions. And this leaves us with the fact that in 2022, that a postal code remains a better predictor of health outcomes than a genetic code. And that is, again, something that was very real in the years prior to the pandemic. But we felt, as especially many of us living in a city, started to see these inequities in ways that maybe families had not experienced before. And I'll get into a little bit around what some of that data look like with respect to the health inequities, but also some of the things that had happened and the resilience and strength in communities to fight and push back against, again, long-standing structures of systemic discrimination, of chronic neglect that have played out for elders in long-term care homes, and especially in terms of access to a number of healthcare resources that were playing out in real time with very dire consequences. And this is the map we look at in terms of how we've really seen the tale of two pandemics play out with respect to, here on the far left is a map on income that was looking at where we've seen high to low income throughout the city. And there was some great work from colleagues, Dr. Rick Glazier and others at the University of Toronto and at the Institute for Clinical Evaluative Sciences that were able to track early on about where was their primary care access relative to poverty and affluence in the city and in the province. And we saw a complete mismatch, actually, between where we were seeing these family health teams, which are really seen as the gold standard of primary care access, where you not only have access to a primary care physician or nurse practitioner, but also a whole host of multidisciplinary professionals, from dietitians and social work to other nursing supports. And where there was wealth and affluence, there were family health teams. Where there continued to be disease burden and poverty, there was not that investment. And again, this had real ramifications when we talked about aspects in terms of accessing testing, to vaccines, to many of the other supports that were required, and will continue to be an issue, I will argue, with respect to long COVID and the potential for long COVID. And again, some really world-leading work from the Science Table and many other researchers here in Toronto, here in the province and in Canada on long COVID as a potential and very serious chronic syndrome. And of course, here we've seen the COVID-19 map. And really the argument that we've made in many communities is that COVID seized on the social fissures. It really did go hand in hand with the pathologies of poverty, and where we saw, again, chronic neglect. Those were the pre-existing conditions for COVID. And so it really seized in areas of poverty, areas where there are already less healthcare resources and social care supports. And this has been the ongoing story. And again, when we talk about chronic neglect, as Dr. McGeer and Dr. Brown have mentioned, again, around the failure, I would argue, in protecting our seniors and elders in long-term care homes, and actually how poorly we do on a percentage of public spending on long-term care and home care. And again, all of this setting very tragic outcomes that I think many of us are still trying to work through. And I also then, wanted to have this from an element of hope and resilience I want to speak to in terms of the leadership. And again, I am so fortunate to have been able to do this work with community leaders, with friends and colleagues that, again, the last 2 years, in no doubt or no uncertain terms, become lifelong friends and family in terms of the work that was done. I just wanted to really show this picture to me of which was the defining leadership on the community vaccine rollout. Really, when we see, this was almost a year ago to the day, this was in April 2021. And the science table and many other organizations, many other researchers that have been mentioned, were able to show and lay out that we actually had seen a monstrous disparity with respect to where vaccines were being made available. And again, this was at a time of very relative scarcity in terms of where the vaccines were being made available and where there was disease burden of COVID. And it was affluent neighborhoods that had very low levels of COVID relative, that had almost access to all of the vaccine. And neighborhoods like Brampton, the northwest of the city, Jane and Finch, where this clinic was in Tobermory, that continued to have double-digit test positivity rates of COVID and did not have access to the vaccine. And some of the arguments early on were about vaccine hesitancy, that communities of color, that Black, Brown, and Indigenous communities, their populations did not want the vaccine, that there was real hesitancy, was not going to be taken up. And so those are some of the justifications that we heard publicly at certain times or privately in certain rooms about why we were sending fire trucks to where there were no fires. And that while parts of the city, as you've seen from the map, were on fire with COVID and we're not having the protections that people needed, as Stany and others have mentioned, from paid sick leave to aspects to being able to isolate and being underhoused or not having housing at all, which I'll get into is one of the roles that we had in playing in ensuring that people who were surviving homelessness were getting access to supports in the vaccine. And it was one thing that I really thought in Stany's talk, which was great in terms of, well, if you build it, people will come. And the early thinking around the vaccine rollout was, well, if you ensure that we've got hospitals and certain vaccine clinics, if we set these up, people will show up. And that's actually not the way that it works in taking an equitable approach in ensuring that you are getting the resources out to where people are at and they are being delivered by people that communities trust or that are part of their own respective communities. And again, this was in April 2021. It was the first, one of the first community vaccine pop-up clinics, meaning that people did not have to book. It would run for the entirety of the weekend. This was the leadership of community health workers who were going door to door, executive directors who were here, and managers from our team at the Gattuso Center for Social Medicine, who were able to lift this up. And we saw over 3,000 people in those 2 days. And there were lineups for kilometers that we had videos of just showing that, the obliteration about vaccine hesitancy, and that this was really about the barriers and structural barriers that were in place when we were continuing to try to set up healthcare delivery, as we always have, but many of us have argued continues to shut certain communities and populations out. And so I have lifelong gratitude and lifelong learning from these individuals who were just bona fide heroes in the pandemic in getting the vaccine out to where people were at. I would like to talk a little bit about, again, in this being data informed and also driven by some of the stories around the health inequities, just how drastic this the social determinants played out. So if you were an individual who did not have a place to live, as we know, there are tens of thousands of people across the country. If you were living, surviving in shelter or encampment, you were 20 times more likely to be admitted to hospital, 10 times more likely to be in the ICU, and 5 times more likely to die. This was an evaluation, again, from ICS, the Institute for Clinical Evaluative Sciences, from a team in London, Ontario. And it had, this again, when you look at it, is no failure of people who, again, were trying to either mask or go outside to survive. This was, again, the pathologies of poverty being exacerbated, being compounded, where people did not have the privilege to physically distance. And this really was one of the more tragic aspects that we saw play out. And it really did seize upon our failure on housing as a human right in Canada, which was also identified, again, back in the Lawn Report, as something that we didn't, in February of 2020, believe could haunt us so badly. And this is, again, an image of an individual, Mark, who was actually someone who is surviving homelessness. And again, I credit my dear friend and executive director, Lana Fredo, about that term, because she always, says that, you physicians always want to, change the language, feel better about what's happening. And so some of the literature went from, we no longer in academic writings about homeless individuals, you say people experiencing homelessness. And that gave us a little bit of relief. But Lana's reminding me, well, this is not like an activity on the weekends or something of an experience. This is really about survival. And we've seen that, again, through the pandemic with that data I just presented. Stories for people like Mark, who had not had their own bathroom and bed throughout this. And this was a collective effort from the city and community leadership and agencies and our hospital to lift up a recovery site for people who did not have a place to isolate, to get the access to their own room, their own housing, as well as the social supports and harm reduction supports that would be needed there, given the disconnect that's played out. And again, that has seen heights of the overdose crisis we have never seen before throughout the pandemic. And I mean, this photo always has stayed with me because, in part of this interview, there was a question that the reporter asked about, how could we ever go back? And people were in tears because for many people, they'd never actually had their own bed and bathroom. And to me, there was the view that, yeah, this is what was driving many of us in working throughout the pandemic, that society will see, people will see that we cannot go back, that here are more humane ways of human dignity, of health economics, of good health outcomes that we cannot look away from. And now we have seen what the solution is. It's permanent housing, and it's not the shelters, which were, very anachronistic solutions. The same way, food banks are not this policy solution to food insecurity. Shelters are not the policy solution to homelessness. And I will, get to this a bit later. We still keep hope, but it was something where, again, many of us, as we are on the potential of some hotels closing down, people having to go back into shelters, many of us will refuse to accept us going back because normal imposed a lot of violence on people and a lot of very, very unacceptable health outcomes that I will get to a little bit with the data at the rest of the talk. And this is sort of looking at the most recent data that mentioned around what's been happening around homelessness and health, and how has this changed and shifted. And it becomes really clear that housing and health are inextricably linked, and that for people who have been chronically homeless, which is for more than 6 months, which again, the initial intent when you go back to the 60s and 70s around shelters was really for less than 30 days and really short-term respite and short-term support has really come into a situation where people are living in shelters for many, many years, and waiting lists are 8 to 10 years to get into supportive housing. And it's very clear that for those folks, who have 3 or more health conditions, that a quarter of them have been homeless for more than 6 months. And again, so we're seeing this really play out as a matter of public health, as a matter of human dignity. And we'll get a little bit to the economics of just how inefficient and inequitable our approach to housing has been in this country. We also have to be very open and clear about the systemic racism and systemic discrimination that faces people surviving homelessness. And as a vehicle of that, I would argue, where we've seen Black, Indigenous, Brown, refugee, and newcomer populations making up close to 60% of people who are surviving homelessness. And part of the last 2 years has really pushed some of us to believe, well, would we ever accept these sort of health outcomes for any other populations? And part of the inaction, part of the real challenge on the ground is that we need to push past these barriers and these long decades of roots of people being subject to the systemic racism. And in many ways, there is no more violent way currently than subjecting people to homelessness, as they argue that there's really no way to achieve good health as people have to move through many of the day-to-day nightmares of survival in homelessness. And again, just to speak to a little bit of how broken the housing system is, again, across the country, and this is really an issue I will have to say quite openly, is about all 3 levels of government. And we need, in across the country, that we need every level of government to step up to end homelessness, cannot be shirked to one alone, but really that we are now talking about people who have been homeless for more than 5 years, for a quarter of the folks who have been trying to either survive in parks, or you see trying to live within and outside a shelter during a global pandemic. So this is something where, again, this is the most recent data showing that shelters have been tried to be positioned as alternatives or solutions for housing or for homelessness, and they really are not. And I think, again, that the pandemic has exposed this in very cruel ways. And this is really the argument I think we have to make, and that I've felt viscerally through the pandemic, and again, in having my background in policy and medicine, that if we are going to deliver on Lalonde's view about universal health care, we cannot do it without delivering on the human right to housing. And I think this is something that we need to see, again, every level of government commit to, and that we cannot look away from. I would like to say just how expensive this issue is on our failure in terms of the human dignity aspect for people like Mark, others, to have to send them back to shelters after everything we've seen, everything we've learned. And really, when we look at the most recent data, we are talking about people who are surviving homelessness living half as long as the general public. So that is a very cruel punishment that none of us would want and ever accept, I argue, for our family, or our children, and our loved ones. And again, I think given the leadership and the expertise in the room, something that I hope continues to be pushed back against with the advocacy that is here at the college and here at the university, as both Dr. McGeer and Dr. Brown have spoken to. And again, when we look at the solutions, this is another Toronto or Canada-based randomized trial, that the Chez Soi study that has had international renown in terms of the outcomes that people who've had experiencing chronic homelessness with mental health challenges, that if they get housing and they have access to mental health supports, there can be dramatic improvements. And I think this is something that Stani has alluded to, and that we've been privileged to have these conversations with a dean who deeply understands this, that we in many ways lead on some of the policy reports that we put out, back, whether it's about the social determinants of health or producing the evidence around housing and health, but we have failed to execute and implement here in our own country. And again, it is certain populations that really bear the brunt of our failure on this inaction, and not to make the choices. And this is really about the choices that need to be made and where our commitments and priorities are going to be. And I mean, I do want to also have that there is, some elements and pockets of hope and great community leadership across the country to try to address this. Is one of the things where we've been fortunate to work with United Way and Parkdale Queen West Community Health Center as the University Health Network to try to lift up a housing solution and to think differently around our role as the University Health Network. We are not the University Healthcare Network. And again, this goes back to one of the thesis of the talk and the presentation around broadening our notions of health. And if we do not address and try to leverage our resources as a large multi-billion-dollar healthcare organization here in Toronto to be thinking about housing, and not only thinking, but acting with the resources we have and partnering, which I think is very different. We've seen throughout the pandemic with community partners across sectors, that these kind of partnerships are so crucial. We are lifting up 51 housing units for our most underserved patients in the emergency department and general medicine wards this September of 2022. And again, this is, I think, something where you're having this happen with municipal government, the federal government, hopeful about the provincial government support. And of course, 51 units, we're talking about close to 10,000 people now who are surviving homelessness in our city, is not going to be a solution. We do need to see, though, these kind of efforts scaled, and these sort of partnerships, both with private and public sector, would be my position on this. We are dealing with the forest fire or a crisis of homelessness and a crisis of the overdose aspects taking place where people are not getting the supports they need. So I think this is one, positive step in terms of social prescribing and a health network thinking differently and acting differently. But we really need to see this scaled at a much higher level and broader level across the country. And I also think, this is an argument and one that many of us at the university and at IHPME, the Institute for Health Policy, have been talking about is, well, when we see things work, why aren't we scaling them? But the other argument is we've not had a dynamic or structure of evidence and evaluation and government. We've not really been investing enough, I believe, in better understanding these sort of interventions that can work, whether it's housing and health, whether it's different models of primary care delivery, of community health workers that go out and are able to help really integrate health and social care aspects that we know now more than ever have very serious impacts on health outcomes. My argument would be, we need to spend more than the 0.03% that when you look at a budget at the Ministry of Health of $63.5 billion is going towards healthcare spending. How much of that are we using to be able to best understand what works? And I think the other challenge when we speak about our healthcare system, and we've talked a little bit about this with respect to long-term care, is the fragmentation that has taken place. And that happens for me as a primary care provider, many of my colleagues here in the hospital. But fragmentation, lack of coordination, are really some of the major aspects that ail our healthcare system. And we've seen actually in some ways more fragmentation in recent years when we have a Ministry of Health, a Ministry of Long-Term Care, a Ministry of Mental Health. It's a very different direction than we had sort of a Ministry of Health and Social Welfare. And one of the things I hope is that we can actually see this integration that took place throughout the pandemic become more sustainable, to be able to respond quickly. And again, there were so many heroes in this pandemic, public servants to health workers, to people, across the city that were able to pick up the phone and call and do things differently and quickly at a scale that we've never seen before. I mean, again, we talk about solutions, from income supports. Pre-pandemic, people would say, well, things like a basic income can't happen. And again, the university and our city is so lucky to have leaders like Hugh Siegel, who've been pushing for basic income for such a long time. But we saw that when the pandemic did hit and there were real threats to people's income and security and well-being, we were able to mobilize a CREB program in a matter of weeks. And I hope this is the spirit and this is the sort of motion that we can see that does remove these obstacles and sees different ministries, different sectors work far more closely together to achieve the outcomes that we saw play out throughout the pandemic. And I will leave it with this as, again, open and again, a real privilege and honor to be able to be here to speak with you and have the conversation, given all of the expertise in the room. But really, this again, was a closing line in Lalonde's report that also really stuck with me, is that as we are coming to a different tenure and stage or cadence of the pandemic, that this will be about the choices, and we will be judged by the choices we made in the pandemic. And I would argue that we would, many times early on, we did speak about that we would be judged in how we protected our most vulnerable or those most at risk. And I would argue that we did not attain on that front the outcomes that we needed to. But in knowing the numbers and the people and the families affected and the lives lost, how will we honor them moving forward? And this will really be about the choices that we make as a society and that we make as, again, governments coming together, because the true limitations of our system were shown, the heroism of individuals came to light. But if we do not address the systemic aspects, the systemic failures, it will continue to be a punishment for populations on repeat that, again, has played out for decades. And so I really appreciate the opportunity to be here, and again, grateful for the learning that I've had on the ground and the vaccine efforts, both in shelters and communities, and hopeful that we can start to see this come together in more and more policy responses. So much appreciated.